Welcome back, everybody. David here again with Med School Boot Camp. So in this next video, it's a bit different stylistically than what you're used to, but we're going to talk about a variety of different conditions that fall under the umbrella of pediatric fractures. So the key ones that we're going to talk about today include the Bowen fracture, the green stick fracture, the torus or buccal fracture, the Salter-Harris fracture, and the supracondylar humerus fracture. But before we start, just kind of general overview. Pediatric fractures can occur in a variety of different ways, right? Typically kids are active, they fall, they're at recess, they're on monkey bars, they're doing all of these things that can lead to fractures. But a couple of key things that are unique to pediatric patients revolve around the youthfulness, if you will, of their periosteum. And recall the periosteum, if I just do a simple bone sketch, let's just say this is a long bone, this is the cortex of the bone, right? The outer hard cortical bone versus the spongy bone that might be seen in the distal or proximal portion of the bone. But then we have the periosteum. The periosteum is a thin layer that's actually surrounding the bone. And this is super important. This is a membrane that surrounds the bone that has a bunch of vascular blood supply, which helps provide nutrients to the bone. Now, the thing about pediatrics and pediatric fractures, that two key things apply here. Their periosteum is thicker than adults. And why is this important? Well, you'll see as we talk about a lot of these fractures, kids tend to have a lot of incomplete fractures. That is to say, they don't have a full fracture across the entire bone. One side might be broken, but not necessarily the other. Or they don't fracture at all. They just get some bending in the bone. And this has to do with the fact that their periosteum is thicker than the adult counterparts. It thins out over time relative to the bone growing and expanding through the elongation process of the bone. The second key point about the periosteum in children is that it has a higher metabolic activity compared to adults. And this helps explain partially why pediatric patients actually heal and recover faster from their fractures than their adult counterparts, because they have more metabolic activity, more blood flow, more supply to those bones. And that has to do with the fact that their periosteum is able to allow that to occur. So hopefully this kind of sets a general framework. But now, if we talk about the specific fractures that we're going to potentially be tested on for pediatric patients, the Bowen fracture is one of the first ones I want to talk about. And the Bowen fracture is fairly simple, right? It's just a bending stress to the bone that does not disrupt the bony cortex and leads to an incomplete fracture. This is commonly going to be seen at the diaphysis of the ulna, which is one of our forearm bones along with the radius, and the fibula, which is the bone that hangs out right next to our tibia in the lower leg. Because this is an incomplete fracture, it's typically going to be managed with splinting and or casting. If you draw your attention over to the Bowen fracture image, which I'll highlight here in yellow so that we can take a closer look, you'll see that this is very appropriately named, right? This is called a Bowen fracture. Well, look at the arm right here. There's not a true fracture line, right? We'll see a true fracture line in some of our upcoming fractures that we're going to talk about, but rather there is a bowing of the bone. So this is the radius here. You can see that extended curvature and you can really see it on this image that this is bowing. This can actually repair itself and children are able to come back from this without needing surgical intervention. Again, pediatric patients due in part to the periosteum have a remarkable ability to not only heal fractures, but actually remodel the bone and put it back into its normal anatomic alignment. Now, the next key fracture I want to talk about is the green stick fracture. And this typically occurs when a bending stress is applied to the bone that leads to bone failure on the tension side in an incomplete fracture. This is to say the convex side is disrupted. So what does that mean exactly? Well, if you draw your attention to our green stick fracture, which I'll highlight in pink, we can take a closer look. In the green stick fracture, we have a side that fails and one side that does not. That's why it's called an incomplete fracture. So if you draw your attention to the fractures, which you can kind of see in both bones right here, it's this kind of line in the middle, you can see that one side is more disrupted, I would argue this side, compared to this side. When we talk about the convex side versus the concave side, this terminology is often referring to lenses and physics and things like that. But a concave or a concavity means that something is curving inward. So this is concave, right? You think about like a little bit of a cave. That's what I think of. And then a convexity is the opposite, where something is actually curving outward. So this is the outside over here. This is the inside over here. And so the convexity is curving outward and a concavity or something that's concave is curving inwards. So you can appreciate here, right? This is kind of curving outwards on this side and inwards on this side. So which side is affected in this condition? Well, since this is going outwards, this is the convex side that is most affected. So if you think about a force that was applied this direction towards the bone, this would be the compression side or the concave side, and this would be the tension side or the convex side, is where there's a disruption of the periosteum. We see that more of the bone is kind of broken on that side. And a great way that people think about these is to think about a green stick fracture, part of the naming nomenclature of it. Think about snapping a green twig. So a green twig is kind of a younger stick that doesn't always break fully in half. So if you're taking it and you're applying pressure to it, which I won't apply too much since this is not a green twig and this is an Apple pencil, but I'm applying pressure on one side, right? That is my compression side. And you imagine that this side snaps open like a green twig. That would be my tension side. And that's what we're seeing here, is that if you snap the twig and you apply tension this way, this side kind of just bends, but this side actually snaps open, and that is where the fracture occurs. So again, green stick fracture, think about a green twig, you're snapping in your hands. Think about which side is actually going to bust open. It's going to be the side that's facing away from you versus the side where your thumbs are should actually stay intact. Additionally, they'd like you to know that this is commonly going to occur at the diaphysis of the fibula, radius, or the ulna. Now, if we draw our attention to our next classic fracture, we have the torus or buccal fracture. We'll see in a second why this is often referred to as a buccal fracture. This is going to often be due to an axial force to the bone, which leads to disruption of the bony cortex and an incomplete fracture. Just as a reminder, what is an axial force to the bone? Well, if you have a bone that's this way, an axial force is going to be either going this way or pulling away, versus a perpendicular force is going to be coming at it from the side or from an angle. And so it's important to keep that terminology in mind and will help us understand this fracture's presentation. Now, in this condition, it's classically said that the convex side remains intact with minimal bony angulation. Again, this is kind of the opposite of what we talked about where the convex side is disrupted in green stick, but it's more likely to be intact in the torus or buccal fracture. Additionally, this commonly affects the distal radius and ulnar bones. And if you draw your attention over to our image right here on the far corner of our slide, which I'm highlighting in orange. So here we have the torus fracture, again, also called the buccal fracture. And take a second, where do you think the fracture is in this image? That's right. The fracture is going to be in this area right here. This is the distal portion of the radius. And look at this. Buccal fracture, right? So how does this occur? Well, we said it's an axial force typically, right? And so if you think about forces coming and compressing this area and creating the fracture line, this is why it's called a buccal fracture. Imagine you have something like an ice cream sandwich. Let's say you go to bite into that ice cream sandwich and you squeeze down on it really hard. Well, what's going to happen if you apply pressure to that ice cream sandwich? Well, the ice cream in the middle is going to do what? It's going to kind of come out the sides a little bit. And that's how I think about these torus or buccal fractures. If you apply pressure, axial pressure to the bone, what happens? Well, the bone kind of squirts out the side a little bit, and you can see this hyperintensity, this compression fracture line in the bone itself. And this is important because one side is often affected more than the other. It looks like it's bulging a little bit more on this side to me based on this imaging. And so in this type of fracture, we often say that the disruption occurs on the concave side or the side where there's more compressive forces, which appears as a bulge. So this is probably the concave side. This is probably the convex side, which is more likely to be intact. It's not perfect, right? It's not exact, but you can kind of see there's a bigger bulge here than on this side. So this side, the periosteum is less affected. It's more likely to be intact, whereas this side, the periosteum is more likely to be affected. This type of fracture is usually managed with immobilization and a splint or a cast for several weeks. Again, it's a shorter time period than most adults because children have a remarkable ability to actually heal themselves, including their broken bones. Next, I want to draw your attention to the Salter-Harris fracture. So this is one I just want you to be familiar with a couple key points because this can get very complicated. There's a lot of different types, but this is a fracture involving the epiphyseal or growth plate. Again, this is classified as type 1 through 5 that you don't need to know at this level. But why is this such a big deal? Well, the growth plate, right? Pediatric fractures, something problematic happening in the growth plate can be a big deal. This is commonly going to occur at the distal humerus or the radius, and what's a classic complication is that limb length discrepancy can occur. Why? Well, if you affect the growth plate, you affect the epiphyseal plate before a child has fully finished growing during that phase, and you damage the structures, you damage the cells in that area, that can affect the ultimate growth or the ultimate lengthening of the bone, which can be a big problem for somebody who's young or who hasn't gone through their growth spurt yet. And so if we draw our attention to the Salter-Harris fracture image, which I'm highlighting in blue, we can take a little bit of a better look. So the Salter-Harris fracture is a fracture of the growth plate. So we have some nice arrows here. This is showing the growth plate line you can kind of see, and then you can see the fracture line, which is shown with the red arrow. So there's a lot of different ways these Salter-Harris fractures can present. There's a lot of different fracture patterns, and again, they're labeled 1 through 5, not important at this level. But the key point here is that when a fracture disrupts the growth plate, we have some type of Salter-Harris fracture. And what's a very important complication to be aware of, it's going to be affecting the growth or a leg length discrepancy, which can occur later on in life. Now, to finish out this video, we have arguably the most important fracture I need you to know for test day, and that is the supracondylar humerus fracture. Sometimes this is just abbreviated as SCH for supracondylar humerus. This is going to be a transverse fracture at the distal humerus. And just as a quick reminder, if you have a long bone, a transverse fracture typically just goes right across the bone versus something like a spiral fracture, which might go up the bone, kind of spiraling, or maybe even a linear fracture, which goes right down the middle of the bone, or even an oblique fracture, which is kind of similar to a spiral fracture, but doesn't necessarily spiral all the way around the bone. It more so just takes that oblique angle. But the key to know for this one is that this is typically a transverse fracture right across the bone. This is the most common pediatric elbow fracture, and very important complications include damage to the brachial artery or median nerve injury. So let's take a closer look at our image, which I'm highlighting over here in green, and that will allow this complication to make a lot more sense to us. So the SCH or supracondylar humerus fracture, again, we said it's a transverse fracture right across the bone that is often going to occur after a fall, specifically a Fuchs injury or a fall on an outstretched hand, or even a flexion injury where you fall onto the elbow posteriorly. But the key thing to know here is, one, this doesn't look very good. This is significant what we call displacement, right? So if the bone is normally supposed to be in this area right here, this is displaced in that it's away from that area, and it's also angulated, right? Instead of going this direction, it's now going this direction. So we call that angulated. But the key point I want you to know here is what structures run in this area. What nerve runs right over this area, right? Let's imagine that the humerus in its normal position right here was a very important nerve that runs right over this area down the arm, and that is the median nerve. But wait, there's more. What's another really important structure that runs down the front of the arm? It's a vascular structure, and that is a big artery, which is known as the brachial artery. And so you can kind of get the idea, right? If the humerus is supposed to be in this position and now it's broken and it's angled out this way, and that's where we have these really important structures right here. And look at these jagged edges from the bone. You could lacerate the artery. This could cause a huge hematoma, a lot of blood loss. You could damage the median nerve, which we know has tons of functions for the arm and the hand because of the location of this fracture. This is why it's so important to be mindful and check these patients and check their neurovascular exam. In the previous video, we talked about radial head subluxation and how patients have a normal neurovascular exam, but in this condition, we are not likely to have a normal neurovascular exam, right? There's too many structures in the way that can be affected. You might have distal pulses that are weak. You might have an abnormal sensation or strength when you're doing the neurological testing. So again, comparing something a little bit more benign like the radial head subluxation versus a supracondylar humerus fracture is very important for any pediatric patient that's presenting with elbow pain. So just a quick summary to wrap up this video, and then we'll finish with a practice question. Pediatric fractures typically have two key differences compared to adults, and that is because of the periosteum, which is thicker, more likely to lead to an incomplete fracture, and the increased metabolic activity, more likely to decrease the recovery time because they're getting better blood flow and better nutrients to that area. Bowing fracture, it's more so just pressure causes molding of the bone in the wrong direction. A green stick fracture, you want to be thinking about breaking a green twig and how one side is going to be compressed but not necessarily break, and the other side is actually going to pop open, which is the tension side. The torus or buccal fracture is going to classically be an axial force, and we talked about the ice cream sandwich, right? You squeeze down on it. What happens? The ice cream squirts out the sides, and this is kind of what is happening here, as you can see this fracture line in the middle. Salter-Harris fracture, main things to know about this, it involves the growth plate or the epiphysis. In pediatric patients, this is a big deal because damage to the growth plate can lead to what? Limb length discrepancies. And finally, we talked about the supracondylar humerus fracture. Main things for this, it's a transverse fracture, and the complications can include damage to the brachial artery or median nerve because of the anatomy where those structures run right in front of the elbow. They can get damaged if this were to occur. So a potential way they could ask about this in a question stem is to give you something along the lines of, an 8-year-old patient presents at the ED after a fall during recess. The patient reports he was running after a friend when he tripped and fell forward on his outstretched hands. He immediately felt pain in the right upper arm. On examination, the patient has decreased sensation to the anterior forearm and the palm. Radial pulses are faint in the right extremity. And the question could then ask, injury to which of the following vascular structures is the most likely reason for the faint distal pulses? And so here they can give you a lot of different options. They can give you venous structures, right? They can give you arterial structures. They can talk about the subclavian arteries. They can talk about the brachial artery, maybe even the axillary or radial artery. But the best option for this condition is the brachial artery is the most likely reason for the faint distal pulses. And again, this has to do with knowing our anatomy, is because the brachial artery is the one that runs right over the area, which is probably affected in this patient. They fell, they likely have a supracondylar humerus fracture, and the closest vascular structure to that area is the brachial artery.